Good morning, good afternoon. Welcome to today's presentation, Sexual and Reproductive Healthcare Access for Newcomers in Canada, Trends and Barriers to Care. Before we begin our presentation today, we would like to begin with a land acknowledgement that N4 is hosted at CHEO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Colleen Drake. I am N4's Project Engagement Coordinator, and I will be hosting and moderating today's presentation with my colleague and co-host Yusuf Khalil, N4's Communication Specialist, who will be monitoring the Q&A box today. I am now pleased to introduce you to today's presenter, and I am going to ask that Sarah turns on her video as I introduce her. Sarah Anderson is a white, queer, cisgender woman who lives in Hamilton, Ontario. She is a registered midwife who began clinical practice in 2015. Through her work as an outreach midwife with the Oracle team in Ottawa from 2020 to 2022, she strived to reduce barriers to perinatal care and provide safe and supportive care through trauma-informed and anti-oppression frameworks. In 2023, she earned a master's degree in health policy and equity from York University. Her original research focused on social and structural determinants of perinatal health and the role of midwifery in caring for marginalized populations. Sarah is passionate about reproductive justice and harm reduction and was thrilled to join Action Canada in December of 2023 as an Access Line Navigator. She is now the manager of the Access Fund program. Welcome, Sarah. Just have a few other housekeeping slides to jump through before Sarah gives her presentation. So here we go. We just would like to state that our presenter does not have any conflicts of interest to disclose. Today's session is being recorded and will be uploaded to our N4 platform. We will share this with you as soon as it becomes available. Should there be any technical issues during this presentation, we will inform you with details of an alternate makeup session. Before we begin today's event, I would like to take a moment to introduce you to our platform feature to help enhance your participation experience. Throughout today's session, we invite you to write your questions in the Q&A window. We know that sometimes many of you might have the same question or be interested in a particular response. Today, you have the option of upvoting a question. Please upvote questions you're interested in hearing the answer to, and we will prioritize those questions to the speaker first. N4 is pleased to announce that select webinars are now approved and accredited. Members of the Royal College of Physicians and Surgeons of Canada, the Canadian College of Health Leaders, and the Canadian Psychological Association earn credits towards their maintenance of certification requirements by attending select N4 webinars. With that said, let's jump right into today's presentation, and I will pass the virtual podium over to Sarah to take it away.
Thank you, Colleen, and welcome everyone. It's great to have been invited to give this webinar, and yeah, thank you for your time today. So I'm just, before I share my screen and my slides, I'm also just going to start with a land acknowledgement. So I'm calling you today from Hamilton, Ontario. And where I reside is situated on the traditional unceded territories of many nations, including the Erie, Huron-Wendat, Haudenosaunee, and Mississaugas of the Credit First Nation, and within the lands protected by the Dish with One Spoon Wampum Covenant. So bear with me and I'll get my slides pulled up here. Okay. Sorry, folks, just one second. The Zoom screen is preventing me from accessing what I want to do. There we go. All right. So again, my name is Sarah Anderson, pronouns she, her, and I'll be talking to you today about sexual and reproductive healthcare access for newcomers in Canada and discussing specifically some of the trends in barriers to care. Um, Colleen already has done a lovely job with an introduction, so I don't really need to go into this again, but I am a registered midwife, currently not practicing, but did the outreach work with the Oracle team in Ottawa for about 2 years. And when I first joined Action Canada in December of 2023, I started out as an access line navigator, which you'll learn more about today. And then in April of 2024, I moved into my current role, which is as the manager of the Access Fund program. Just a little bit about Action Canada for Sexual Health and Rights, who we are and what we do. We were formerly known as Planned Parenthood Canada. We are an organization of, I think, approximately 28 individuals at the present time, predominantly working virtually across Canada. We have staff in several different provinces. Our teams, our organization is divided into sort of four main teams. So we have our communications and fundraising team, our policy and advocacy team, our operations and fundraising team, and then health promotion, which is the team that I am a part of. And our organization, just sort of the main work that we do that's highlighted here, we work to advance and uphold sexual and reproductive health and rights in Canada and globally. We also are striving to increase equitable access to sexual and reproductive health information and services. That's a big part of what our health promotion team is a part of. We work to educate governmental and non-governmental actors and also to support movements to advance an intersectional sexual and reproductive health and rights agenda. And as we get a little bit more into the content today, you'll see why that intersectional approach is particularly essential to the work that we do. Um, okay, so um, just a few examples of some of our recent advocacy and education campaigns, although you can certainly learn a lot more by visiting our website. There's lots of information there. But in the last year, especially, our policy and advocacy team was quite involved in work for comprehensive pharmacare, including universal access to contraception for all Canadians. Um, we learned recently, and some of you may also be aware, that in the province of Manitoba, they launched free contraception for those who were eligible, I think beginning in October of 2024. And since that was launched, approximately 32,000 Manitobans have accessed free contraception. And so that should speak for itself in terms of the need, the demand, and why we will continue those advocacy efforts towards access to contraception, particularly free contraception. Another example of some of the work that we do. So it was formerly known as Sexual Health Week, but we had our Sex Plus Week 2025 that was just in February last month. And this is our annual awareness campaign dedicated to sexual health education. We also want to challenge misinformation and disinformation, confront stigma, and also work to dismantle barriers to accessing sexual health knowledge and healthcare. Something that I wanted to draw everyone's attention to today in particular, and this information is also something that we provide to a lot of the folks that reach out to us on the access line. So our sexual health info hub, and you can see the link to the website there, although you can also Google it very easily. So this is where we provide reliable, so evidence-based, sex positive, inclusive, and pro-choice information about sexual health. And then you can see there the key sections of this info hub. So birth control, sexually transmitted infections, etc. This is one of the main resources that we would often sort of direct clients to who are calling into the line. But it's also, we have some amazing trained volunteers that work on our access line, which I'll get into in more detail. But we also draw from this information as well when we're working on the line to support individuals calling in for information and support. Okay, so I'll talk a little bit now about my team, so the health promotion team, and specifically the access line, and a little bit about how we operate. So although I oversee the Access Fund more specifically. I'm also the direct supervisor for our 5 full-time Access Line navigators who are truly amazing individuals, and you'll begin to understand why. The work that they do is incredibly important. So we are available 7 days a week from 9 a.m. to 9 p.m. Eastern. And so we have our 5 full-time navigators working during the week, and then we have our trained volunteers evenings and weekends. We've recently onboarded a new group of volunteers, and we're looking to onboard approximately twice a year moving forward. We are available by phone, text, or email, so people can reach out, yeah, through various ways, making it even more accessible for individuals. There are a lot of people that would prefer to just have text conversations, and so that's always available. We also have interpretation services available if needed. For phone conversations, we will actually call our interpretation service, and then the navigators or the volunteers also will use a text translation service online that we have found to be incredibly reliable. Our access line is, of course, like I mentioned, evidence-based, but also confidential, non-judgmental. And we work to provide, I mean, all sorts of things, but generally, this is sort of a summary of what I wanted to capture today. So sexual health information, but also connection with services. So we do make referrals as needed. Information as well as referrals for pregnancy options and abortion, and I'll get into that in a little bit more detail. Systems navigation support. So this is a big part of what our navigators do. And this is something that is particularly important for, as you can imagine, a lot of newcomers to Canada. Being able to navigate our often incredibly complex healthcare system is a really important part of what the Access Line does. Emotional support, which is pretty much woven into the work that we do. But is also very critical. And we, as a team, are continually doing, education, training, professional development. All of the navigators and some volunteers recently completed a full-day workshop in trauma-informed practice, but also as an organization, Action Canada, quarterly, we do anti-racism, anti-oppression workshops so that we are staying yeah, up to date and always making sure that our work is being done through that lens. So that also, yeah, lends itself well to the work that we're doing with the health promotion team. Finally, pregnancy options and post-abortion counseling. This is becoming increasingly a big part of the work that's being done on the line, where we are certainly not trained therapists or counselors, but we do have the training to be able to provide some of that options counseling, but also emotional support if people are struggling after an abortion or after a miscarriage. And then just something to draw attention to, even though some of us who work on the health promotion team are trained healthcare providers, we are not wearing that hat, so to speak, when we do this work. So we're not actually providing medical advice or clinical advice, nor do we, as I mentioned, provide long-term counseling or therapy. And we are also not considered to be a crisis line, even though people often do reach out to us in a state of crisis. So I'll talk a little bit now about some statistics from 2024. This is just about the access line in general. And these are consistently the top four reasons that folks are reaching out to us. So information on abortion. Sometimes it's just that people have questions and they need a little bit more information. Other times it's that they are looking to be referred to providers. We have a very comprehensive provider directory that we've been building over the last several years. And so we're able to search based on the caller's location, and we can provide them with information about where they could go to access services. And then, depending on need, some of these calls will then actually end up being referrals to our access fund. Um, and I'll talk about that in more detail. STIs, as I mentioned, so questions about transmission risk, also referrals if people are needing healthcare. Pregnancy overall, just as a topic, in terms of pregnancy testing, risk assessment, and again, options counseling for people who are uncertain about what decision they would like to make about their pregnancy, and then contraception. We get a lot of questions about contraception, what's available, how to access it, and emergency contraception as well. So I'm going to talk now about the Access Fund program, which is also known as the Norma Scarborough Emergency Fund. And this is for individuals who are experiencing any type of financial barrier to accessing abortion care specifically. So we use this fund to contribute to both medication or procedural abortion costs, but also any costs related to travel, hotel accommodations, and then some examples of incidentals that you see there. The source of this funding, so we have three main sources. We do receive direct private donations to our Norma Scarborough Emergency Fund. Our fundraising team is obviously quite important there. And then we also receive funding and have for the last few years from Health Canada's Sexual and Reproductive Health Fund. And for the last 2 years, we've also received a Shoppers Foundation community grant to be able to continue the work. Um, it's worth noting that these funds are completely depleted annually, and we've been seeing the funds being depleted more rapidly each year. This is for two main reasons. One is that we've seen a significant increase in case numbers, especially in the last 2 years. Our case numbers monthly have close to doubled. But it's also that we're seeing, as I'm sure you're all aware, just an increase in how much things are costing. So not just hotels, airfare, trains, things like that, but also we're seeing the costs of certain uh, aspects of clinical care go up. So for individuals who are uninsured, who would otherwise be paying out of pocket for things like ultrasounds, blood work, physician's fees, um, we are seeing things, particularly things like uh, laboratory work, ultrasounds, et cetera, those costs have started to go up as well. And so this is also why our fund is getting more rapidly depleted each year. So just a little bit about how this fund works. So again, individuals are referred through the access line. We are seeing the majority of our access fund clients actually come from direct referrals from providers or community partners. But certainly clients can call the access line and then we determine if they're eligible for the access fund. And then they are brought into or they are brought on as clients, I should say, and we then manage their casework. So our navigators, in addition to answering the line and answering questions, they're also doing case management work for any access fund clients. Only our staff can actually provide and confirm what support can be provided and have access to bookings, payment details, etc. We are not ever able to actually exchange money directly with clients. We book and pay for things like travel and accommodations directly. And something also to note, we do sometimes have clients reach out having already paid out of pocket for certain things. We are unfortunately not able to reimburse clients for costs previously incurred, which is an unfortunate reality, but that is how our fund needs to function. I can get into more details about that if anyone's curious. So some other stats here that are that I wanted to share with regards to newcomers, especially in Canada. And I also just want to note here, just to explain these numbers, our services are intentionally low barrier, just to keep our the care that we provide, the support that we provide, again, safe, trauma informed. We keep it low barrier so that we are only actually collecting demographic information if it's disclosed or if it's actually necessary for support. So if someone goes on to become an Access Fund client, then of course we would need to ask for some more information. But for individuals that are just calling the access line, we would only capture certain information again if it's disclosed. So you can see here that for the fiscal year 2024-25, we've tracked a total of 1,956 conversations. And these are what we consider to be sort of unique users. So that example there of 695 text conversations, those text conversations, that might be a conversation that goes on with an individual sometimes for days or even weeks, depending on the type of support being provided. So that's just a snapshot of approximately, the numbers of what we're seeing in terms of phone, email, and text. And then again, we do have a significant proportion of just unknown information here. But in general, from 24 to 25 in that fiscal year, 482 callers were insured and 461 uninsured. And then of the data that we were able to capture in terms of status, you can see those numbers there. Again, a significant proportion that was just undisclosed or unknown. But we see quite a significant number of international students that are contacting the Access line. And then again, you can see there newcomers or new immigrants, refugees, temporary residents, those who are here on work permits. Yeah, so this is just, like I said, a snapshot of what we saw in the Access line in this past fiscal year. And then some Access Fund statistics. So this is just from 2024. So we provided a total of 640 clients with support. And as I mentioned earlier, many of these individuals are now direct referrals from healthcare providers or community partners. But what is particularly of note here is that of these clients, 354, so approximately 55%, were uninsured. And the most common barriers that we have documented, and these are consistent trends that we see every month, and I would say for the last 2 years, these have been consistent trends. Most common barriers, lack of insurance or precarious status, distance to services. So how far someone is actually needing to travel to receive sexual and reproductive healthcare, in this case, specifically abortion care. Gestational age limits. So this is something that we are still coming up against quite often, where depending on how far along a pregnancy is, there are just no options for care in an individual's home community. And so we do our best to help them navigate that and find out the closest place to receive care. Lack of support overall, that's another huge barrier that we see, and certainly something that can that does contribute to quite a bit of psychosocial stress for individuals that we're supporting. Youth under 25, so that would be another significant barrier that we're seeing, and that's also reflected in the statistics about how many international students we've been supporting. And then communication or language barriers. And one of the things that we see often or that we hear often from the clients we're supporting is lack of interpretation services offered by service providers. One case in particular that comes to mind, there was a clinic that was not allowing a support person to go in with our client, but they also weren't providing interpretation or translation services. And so right away, that's we're dealing with a situation that's not very culturally safe, where someone is going in to receive care and is not actually able to receive appropriate communication and safe communication. So in general, um, with regards to some of the trends and barriers to sexual and reproductive health care, what the work on our front line is capturing is that newcomers to Canada, those who are undocumented or uninsured, they often are facing intersecting barriers. So, for example, financial insecurity, precarious status, racism. We know that these intersecting barriers lead not just to vulnerability, but inequitable access to sexual and reproductive health care and potential poor health outcomes. Some of the other significant trends that we've documented, particularly for newcomers, lack of primary care provider. This is probably one of, I mean, again, I think you're probably all aware this is an issue for many Canadians, not just newcomers, but especially for that population. Also, lack of access to or an inability to afford contraception, which is again why we are still making that a significant priority in terms of our advocacy efforts with our organization at large. And like I just spoke about, a lack of cultural safety. So, stigma, discrimination, a mistrust of the healthcare system. We do hear from clients quite a bit about negative experiences that they've had in accessing care, and we do our best to try to document that because that can also help to inform some of our advocacy efforts as well. Um, Difficulties navigating the healthcare system, as I've already spoken about. This is such a common trend and something that I think is one of one of the most critical aspects of the work that the Access Line is able to provide. Another really important trend and something that we're starting to see more and more is the interim federal health program. So IFHP for refugee claimants, for refugees in Canada, those who have insurance with IFHP, we're finding that there are certain clinics that are not always accepting this insurance, which is obviously an enormous barrier. And what we are learning more and more by talking to clinics, and it's often myself that is reaching out to clinics to try to do some of, some information gathering and some advocacy work to try to find out why IFHP is sometimes being like denied or declined. We're learning from certain providers that it is actually an administrative barrier on their end, that it's too much of a financial risk for them to accept IFHP because of how long they are actually waiting to be reimbursed by the federal government. So this is a bit of a bureaucratic well, it's a problem. Let's just say it that way. Um, we are still working sort of behind the scenes here with our policy and advocacy efforts to try to figure out how we want to address this because those who technically have insurance should not be turned away for any type of healthcare that they're looking to access. And so that's something that we're doing our best to document and to collect some good data on. We do also sometimes encounter, for international students especially, student health insurance plans that don't necessarily cover all aspects of sexual and reproductive health care. So we have run into several cases where the like UHIP, for example, so the University Health Insurance Plan won't cover an abortion or won't cover contraception. So another big barrier for that population. And then, as I've mentioned previously, just a decreased ability to travel. So whether that's due to living in a rural or remote location or just having general lack of access to transportation for various reasons. So the frontline work, again, the data that we're collecting on the front line, I mean, obviously we're there to support individuals, but the work that we do, the information that we collect, the reports that I'm doing every month and the data that I'm collecting is also meant to inform the advocacy efforts of our organization. And so just some examples. The navigators do this quite a bit. I also am sometimes the one on the phone doing direct negotiations with providers, with clinics, sometimes with hospital billing departments to either reduce or waive fees for uninsured clients. And sometimes it really is just a matter of getting on the phone with the right person at the right time and explaining an individual's circumstance and sort of making that human connection and doing that negotiation and advocacy work just to say, help us figure out how we can get this person the care that they need. Here's what we can do. Is there any movement to be able to, reduce or waive fees? We have found that there are several incredible physicians across the country. I shouldn't say several, many, many, who are often willing to waive some fees or reduce their fees. It's a lot harder for us to have standard fees, again, things like laboratory work or ultrasounds, especially at hospitals. We often don't get a lot of movement there. It can be a little bit more difficult to negotiate that. But certain physicians have been really generous in terms of helping us to support those who would otherwise not be able to pay for care and receive care. We also are tracking clinics, like I said, that won't accept IFHP for refugee claimants seeking SRH care. We are documenting client feedback about any negative experiences with providers, clinics, institutions, again, using that anti-racist, anti-oppression lens. That's something that's becoming increasingly important to us to make sure that we are continuing to provide safe and culturally safe referrals. And also noting trends in how far clients are needing to travel to access services, because this is really helping us to see where are the gaps in services across the country. Where might we need to advocate for more virtual care, for example, especially for something like medication abortion or prescriptions for contraception. If we can track, this type of data, it again really helps us to figure out where our advocacy efforts need to go. So I thought I would finish up just to give you a case study. This is just sort of an amalgamation of many, many clients. So this is like a fictional case study, but I wanted to illustrate what what a pretty typical case looks like for the Access Line and Access Fund. So in this case study that I've brought to you today, a 21-year-old living in rural New Brunswick, newcomer to Canada on a work visa, no primary care provider, and also facing significant financial insecurity. This individual reaches out to the Access Line by text, only speaks some English, and so again, that text translation service is utilized by the frontline navigator that has the initial contact with this individual. Um, this client discloses that they have taken a pregnancy test, which was positive, but they're uncertain of how far along. They haven't been able to access any prenatal care. Sometimes people also don't know how far along they are, I mean, for all sorts of reasons, irregular menstrual cycles, etc. But we do encounter this quite a bit, that we know that someone is pregnant, but they are very uncertain of the gestational age of the pregnancy. This person reaching out is experiencing significant emotional distress about finding out that they are pregnant, and they start to ask questions about abortion. That is the choice that they are aware that they want to make, but they have no provincial health insurance. Because, as I said, they're just here on a work visa. The Access Line Navigator is able to provide that options, counseling, emotional support, and then, as I mentioned before, that the systems navigation using our provider directory to be able to refer to the closest available services. We will give that information to the client, collect their information if they're willing to disclose some contact information if they want to be called back. The client then contacts the closest provider, but faces significant challenges due to the language barrier, and there might not have been good assistance in that interaction with the provider or the clinic or the hospital. And so they text back for interpretation assistance. And this is sometimes something that we will also do where we will get on the call with the clinic with an interpreter to try to like facilitate and make that conversation as straightforward as possible. Um, the client does end up going for an ultrasound locally, but does have to pay out of pocket for this and learns that the pregnancy is beyond the gestational age limit for nearby services. We run into this quite often. And so then a plan is made to book an appointment in Montreal. And our fund then would negotiate and cover procedure costs and also cover all travel accommodation and incidentals, including daily meals. This is a very typical example of someone calling into the line and then the case management that would unfold. And we sometimes have cases that can go on for several weeks, depending on how long it takes an individual to find an appointment. Sometimes cases go on for weeks because of uncertainty about the decisions that they want to make. And that's where our options counseling and emotional support really comes in. Obviously, our cases are quite varied and can be incredibly complex. But yeah, I wanted to share this with you today because I think it does capture in general a lot of what we see. And so I thought I would also just give you the information about how to connect with us. It is, of course, available on our website as well. But as I mentioned, the access line is available 7 days a week, 9 a.m. to 9 p.m. Eastern. Phone, text, or email access is all available. And I've provided you with my direct email address as well. So please do reach out anytime if you have questions about what we do, or if you would ever like to just learn more about the program or any clients to our program. I would always be happy to hear from any of you. All right. That is it for me.
Fantastic. Thank you so much, Sarah, for that informative presentation. And I can see from the audience's questions that they have lots to share with you. So we can dive into those. And lots of interest because the top question was, how can we sign up to volunteer? So obviously you shared your contact information. Sounds like there's some great interest there. So um, please reach out to Sarah because I think we have some interested individuals. So, the first question, having worked for years with patients who have experienced abuse, as well as those exhibiting abusive behaviors, I understand how complex and sensitive these situations can be. Could you share what kind of support is provided to patients after experiencing such events and how these cases are managed to ensure their well-being and safety? So, what supports are in place for these patients experiencing either exhibiting abusive behavior or they've experienced abusive behavior?
Yeah, it's a very good question. We certainly do encounter this on the line where clients perhaps have disclosed, experiencing like being a victim themselves of some type of abuse. Again, because we are, usually very clear that we are not trained counselors or therapists, but we do um, hold space for clients, answer any questions, provide that emotional support. But one of the things that we do is refer on. Um, so we have so much information at our disposal. We have worked so hard over many years to collect information about where the best resources would be. And so that's also a big part of our provider directory is to figure out what other services or supports would be available in someone's local community, or how can we make sure that there is some ongoing support for someone um, facing these types of situations. We don't have, again, the training or usually the capacity to provide sometimes the specific supports that someone might need, and so we do our best to, like I said, to refer on to the most appropriate resources.
Fantastic. Thank you, Sarah. This question is, how do you support international students in accessing SRH services, as some are considered insured with the University Health Insurance Plan, but still these services are not free and covered by the insurance?
Yeah, that's a great question. So I did speak about this briefly in the presentation. So if we run into situations where an international student's health insurance plan through their university or college isn't going to cover certain aspects of SRH care, whether that's an ultrasound, contraception, abortion care, etc., we will end up providing the financial support that is needed. We can't always cover 100% of the costs. It really depends on the situation. And this is why we do so much work in terms of negotiating and doing some advocacy work with a particular provider. Um, we we usually will do our best. I mean, we want to always support an individual's choice in terms of where they would like to go to receive care, but we can sometimes also make recommendations about where they could go to receive care that would allow us to cover the care 100%, because we know there are some clinics where the costs are just going to be higher than we can afford. And so sometimes it's a conversation with the client about, while respecting their choice and also saying, these are the limits of our fund. This is what we can do. But if ever there are international students that find themselves in that situation, that's what our access fund is for.
Fantastic. That's such a valuable resource. Thank you to the audience for upvoting the questions. It's making my job quite easy to address these to Sarah. So, how do you ensure that the translators you recruit are trustworthy, given that they handle sensitive patient information?
Yeah, we've been working with an organization now called Access Alliance Language Services, I believe for over 2 years. That's our phone interpretation service. We have received very positive feedback from clients about these interpretation services and have not run into, at least to my knowledge, any concerns about the safety or the appropriateness of those services. Um, we also, in just this last, I guess it's just in the last 6 months, we've also started sending out surveys to Access Line callers and Access Fund clients as well about our services. And so that also allows us to request specific feedback about anything that, I mean, we want to know what we can do better, what might not have been working for them, and that would be an excellent opportunity for us to learn about whether or not any interpretation didn't feel safe or appropriate. One of the things that we will often ask certain individuals is whether or not they would prefer like a female or a female identifying interpreter or translator. That's often a big part of cultural safety for certain individuals, and so that's something we will keep in mind as well.
Excellent. Thank you, Sarah. Um, the next question is, we see a number of uninsured pregnant individuals. Do you know if there's similar financial support options for those choosing to continue their pregnancy?
That is a very good question and a really hard one to answer because unfortunately there is not a lot of support across the country. What I can speak to is that for those who are choosing to continue their pregnancy, if they are eligible, and unfortunately this is only available in the province of Ontario, registered midwives have a funding agreement with the Ministry of Health that allows us to care for uninsured clients completely covered by the provincial like completely covered by the Ministry of Health. So for those of you who are in Ontario, if you are not already aware of this, any uninsured individuals, recently landed immigrants, refugees, etc., midwives can provide all of the prenatal, intrapartum, and postpartum care for those individuals. And midwives usually will work pretty hard to um, set someone up for trying to find a primary provider once we have to discharge them. So again, this is unique to the province of Ontario. I wish that it existed coast to coast, but that would be that's one of the best recommendations I can make is to get in touch with midwives. Otherwise, there is unfortunately not a lot of support for pregnancy care, prenatal care.
Okay. Thank you for sharing that. Um, this is sort of along the same line. So, does your uninsured number mean that there is no provincial coverage or no supplemental insurance?
Both.
Both. Okay.
Yep. So
Excellent.
just meaning that there is no possibility for that individual to access healthcare without having to pay out of pocket.
Okay. Excellent. And then do you provide feedback to the service providers with whom clients have met and had, unfortunately, a negative experience from their learning? Is that feedback shared with those individuals so that can be a learning on their part?
We haven't yet started to do that. This is actually data that I've only recently started collecting since I've moved into this role. We were starting to encounter it often enough that this was data that I wanted to capture. And we are still making some decisions as an organization about what we then want to do with this information. Because I do think that giving that feedback to the providers is really important. As a healthcare provider myself, I certainly would want that feedback if any care that I had provided was a negative experience for someone or felt unsafe in some way. So I'm working with a couple of the directors in the organization to figure out some of the best approaches in terms of what we're now going to do with this information.
Excellent. Thank you. Always good to have those learnings to have a balanced effect. Um, In cases of abortion, what kind of psychological support is provided to patients? Is the focus primarily on preventative support before the procedure, or are there structured resources available for emotional and mental well-being afterwards?
Not sure that I am entirely clear on the preventative piece,
Mhm.
though I think if I understand correctly, um, we will provide a lot of informational support for individuals, especially those who are, they know that they want to have an abortion, but they might be feeling very nervous, very scared. We do our best to provide a lot of information about what to expect. So, our navigators and our trained volunteers are very, very knowledgeable about the various types of abortions. We also, because uh, with we work consistently with so many different clinics and hospitals across the country, we've gotten to know a lot about how one provider or one clinic or one hospital might function compared to another. And so we can give really specific information often to clients about what they can expect. And I find that that information usually helps to at least, emotionally prepare someone for what they're going to experience. And then again, afterwards, especially for our Access Fund clients, but for anyone who's reaching out to the line, they know that they can always call or text back if they want some ongoing support. So that post-abortion counseling piece that we do has become a really important part of the work that the navigators do. Um, we usually will provide up to 3 counseling sessions. And at that point, if we determine that someone is experiencing more distress than we are able to provide, because again, we are not trained therapists, then that's when we are referring on to other services and supports if it's seeming like someone is really struggling. We would never just abandon someone, but we also have to recognize our own limitations there.
Wonderful. Thank you, Sarah. Um, for individuals who have already experienced violence, navigating bureaucracy can often feel like an additional form of trauma. Are there streamlined systems in place to ensure they receive the support they need with without unnecessary barriers? And what measures are being taken to make the process more accessible and trauma informed? So, are there streamlined systems in place to ensure they receive the support they need without unnecessary barriers? So, navigating those barriers and just to make the process more accessible.
It's a really big question um, that I will do my best to answer. I think this is where the knowledge and skill set of our navigator team really comes into play because over the years, we have some navigators that have been, we have one navigator that's been with us for 9 years, a few other navigators that have been with us for about 3 years. And so the knowledge that they've acquired in that time means that when it comes to not just systems navigation, but that safety piece in terms of how can we refer someone to a place that we know is going to be the ideally the most safe or most appropriate option for them, knowing that we might not be able to mitigate all risk, unfortunately. But I think having that knowledge, and this is also where collecting that information about potential negative experiences, where we can if if we have the flexibility or the freedom to do so, where we might be able to redirect someone to a different location, if we've heard often enough that it's potentially, not going to be a safe experience or a trauma-informed experience. Yeah, our provider directory that I've mentioned a few times, we, I mean, it's available at everyone's disposal as they're trying to very quickly pull up information while they've got someone on the phone. But we also keep notes, really detailed notes about certain locations, providers, so that we also have that information available to us to be able to make those decisions in the moment about um, what might be the best decision for someone or what the best recommendation is that we could make. I hope that answers that question. That's
That
a
was a
tough,
tough
it,
question.
it
That
is a
was
tough
great,
one.
Sarah. Yeah, you can also think about that, and we can always get back to the attendees with some more details as well. And they have your contact information to do some follow up if needed. Um, what trends have you seen over time? Are things improving or worsening for newcomer populations when it comes to SRH care access? Hard to tell.
I think it's hard to tell, but what I would say is that I mean, with the increase in case numbers that we're seeing, I would say in general, it means things are getting harder. Um, it means that our support is more needed. It's also, I mean, there are probably a lot of factors. It's possible that more people are just learning about who we are and what's available, but we have seen such a dramatic increase in case numbers that I think it speaks to the fact that there are so many uninsured individuals who are in need of our support and our care, particularly financial support. And I think, as I mentioned too, the overall increase in costs that we're seeing, in terms of, I mean, even just cost of living, where, someone is having to choose between being able to pay for contraception or pay for groceries. That is not a decision that someone should have to make, but that is the reality of, yeah, that's the reality for so many individuals that we speak to. And I think, yeah, so I don't know that I can say with confidence that it's getting better or worse, but I can say that our services are uh, in demand more than ever. And there are other organizations in Canada that were doing similar work to us that have lost their funding. And so this things We're here, we're not going anywhere, we have our funding, but things do feel a little dire at times in terms of what's available for Canadians who are struggling.
Understandable. I think we have time for one more question. So, how are service providers trained to offer sexual and reproductive health care to newcomers? What specific training or preparation do they undergo?
That one I would have to do a little bit of research on before I could give a good answer to. Um, that's just not an area that I know enough about. I know what training I received as a midwife to be able to provide care to newcomers and uninsured individuals. But that's something, if you leave that one with me, I could maybe get a more researched and better response to that
Of
question.
course, Sarah. We've put a lot of questions at you, and um, thank you so much to the audience. They shared quite a few questions. If we did not get to your question today, we will share them with Sarah so that she can answer after the fact. I just want to say thank you, Sarah, for taking time today to participate and present to our members. And like I said, many thanks to the audience for joining us today. We just have a few pieces of information to wrap up, and then I'll hand it back to Sarah for some last words before we wrap up today. So, with that, if you missed any part of today's presentation or would like to watch the session again, we will post the recording on Enforce platform within the next week. We want to continue the dialogue this presentation has started. So, like I said, we'll be moving all questions we did not get a chance to answer to Enfor's moderated discussion platform meeting place. And we have invited our presenter to respond to your questions there. We also have curated several resources related to today's presentation topic. You can find these in our resource toolkit, and we will link them when we share the on-demand version. If you haven't already, please sign up to newcomernavigation.ca. Lots of learning opportunities there. Following today's session, you'll be invited to complete a survey. We appreciate you completing that. And if you have not already, please check out our N4 mobile app currently on the screen. It's available on Apple and Android devices. And I will thank everyone for joining us today and hand it back to Sarah for any last words.
Thank you, Colleen. And thank you all for those very thoughtful questions. I do encourage any of you to reach out to me by email. Happy to answer questions, as I mentioned, but also I'm always very keen to develop new relationships with providers and other community partners. And so, yeah, just if you're looking for more information from me or just want to have a conversation, I'm always very open to that. So, thank you again for your time.
Wonderful. Thank you so much, Sarah, and everyone have a lovely afternoon.